from IPCA. It's a great opportunity today for welcoming our senior doctors from Hyderabad for having a webinar on hypertension. First, I would like to introduce Dr. Rajiv Garg, Senior Consultant Intervention Cardiologist from Glen Eagles Global Hospital, Hyderabad. Sir is going to give a speech on acute MI management of Indian perspective. And secondly, with Dr. Mukesh Rao, who is a Senior Consultant Intervention Cardiologist, Glen Eagles Global Hospitals, Hyderabad. So the sir is going to present on common mistakes in management of hypertension. So there are two topics which are interesting in hypertension. So one of our senior and we want to welcome these two senior doctors who are going to give the presentation on hypertension. So I want to welcome upon Dr. Rajiv Garg for his presentation. So over to you, sir. Thank you. Sir, your audio is muted.
Yeah. Am I audible?
Yes.
Yeah. So good evening, everyone, and a very happy Navratri and upcoming Dashara. And let us start our session sponsored by our sponsors, IPCA, the makers of Revelol. And today they have assigned the task to see how we can manage with slight difference of STEMI in Indian perspective. So yeah, so pre-hospital, the acute coronary syndromes are divided into ST elevation, ST non-elevation, and unstable angina. And now let us see for the pre-hospital management of ST elevation MI. Most important is early recognition. Most of us falter here only. They think it as acidity, some muscular pain, and almost golden hours are lost during this, recognizing the problem itself. So most important is we have to educate our people for the symptoms through various methodology, most common being the media and news, print media and electronic media. So they should be educated what is the symptoms of heart attack, most common being chest discomfort with or without radiation to arm, back, neck, jaw, epigastrium. Any unaccustomed shortness of breath, nausea, lightheadedness, and weakness. Then there should be activation of efficient emergency medical service, that is transfer to hospital by an ambulance or use of centralized numbers. Many places have different numbers. One of them is 910. Then pre-hospital ECG and administration of drugs form a very important concept in which the hospital staff should be trained to perform an ECG at the time of first medical contact. They should give aspirin, tablets of nitroglycerin, and they should be used to the protocols of pre-hospital thrombolysis to whom to be given. So they should know the indications, contraindications, and dosing schedule of various thrombolytic therapy. The most common being used nowadays is tenecteplase. Then timely establishment of reperfusion is the key to the improvement in the symptomatology and preventing deterioration of the patient. Once the patient reaches a STEMI care center, the choice of reperfusion again can be decided if it is not been given to the availability of PCI, time to transfer to PCI capable center, and contraindications to thrombolysis. So this is how STEMI care approach should be approached in a non-PCI capable center and a PCI capable. Undoubtedly, PCI is the treatment of choice if it is available and possible. But because of limitations in COVID times, especially, and the distance and traffic problems, the thromboinvasive approach is coming up. But undoubtedly, if the PCI capable center, the patient is able to go within 60 minutes and reach the CAT table, then PCI is the drug of choice, treatment of choice. Now, if not capable, then we should think of fibrinolysis. Then non-invasive risk stratification should be done. And if the patient continues to have pain because of post-thrombolysis, a rescue PCI, that is PTCA, should be performed or should be shifted to CABG if the vessel is not amicable for PCI. Then if it is ischemia driven, that is patient continues to have ECG changes or pain, again they should be subjected to PCI or CABG. Then late hospital care and secondary prevention follows the PCI and CABG, and this is how it goes on. So the reperfusion, which is the key to the management of ST elevation MI, most important thing what should be kept in mind is the total ischemic time should be kept below 120 minutes if possible. This is 2 hours and ideally 60 minutes, because otherwise myocardial necrosis starts taking place and the benefit of reperfusion is totally lost. So patient getting symptoms, EMS delay should be avoided. Take to the emergency ambulance where we can take a ECG, give basic antiplatelet drugs and thrombolysis if possible. It should reach and diagnose ST elevation MI in less than 10 minutes when you reach the hospital first medical contact. Then time to PCI. If the anticipated time is less than 120 minutes, patient should be subjected for primary PCI, and reperfusion, that is wire crossing, should be less than 90 minutes. If the anticipated time is more than 120, we should consider fibrinolytic strategy and reperfusion lytic bolus should be given. Then the STEMI diagnosis, first medical contact is a non-PCI center. Again, we should go for thrombolysis. And first medical point, if it's a PCI center, if the diagnosis of ST elevation is made, then primary PCI is the treatment of choice and less than 60 minutes wire crossing should be achieved. So the total ischemic time is most important, and if it is less than 120 minutes, preferably less than 60 minutes, PCI should be the first choice, but any delay anticipated anywhere, we should go for thrombolysis. Primary PCI remains the gold standard at a PCI capable center. Reperfusion therapy is indicated in all those patients with ischemia of less than 12 hour duration with persistent ST elevation, class 1 level of evidence A. The primary PCI is recommended over fibrinolysis within the indicated time frame, but if PCI cannot be performed after the diagnosis, fibrinolytic therapy is recommended within 12 hours once the patient is ruled out of contraindications. Again, this also is a class 1 level of evidence A. Then in PCI capable centers, primary PCI is the gold standard. Non-thrombolized patients less than 12 hours of onset of chest pain, primary PCI within first 12 hours, onset scores over thrombolysis, but if PCI delayed more than 120 minutes, do thrombolysis. Non-thrombolized patients 12 to 24 hours, immediate PCI should be performed in patients with clinical or electrographic evidence of ischemia. In less than 24 hours of onset of chest pain, pharmacoinvasive therapy followed by immediate transfer to a PCI capable center. Then accepted delay for PCI exceeds 60 minutes, thrombolytic therapy should be given. This can occur in COVID times when we need a single cath lab operated centers where we need a report of RT-PCR, or the patient and the cath lab is busy doing another procedure. Those are the situations in which again thrombolytic therapy should be given to the patients. Now, fibrinolytic therapy, it's useful within 12 hours of symptom onset when PCI cannot be offered to STEMI patients. Useful when initiated in non-PCI center if the delay is more than 120 minutes. Should be initiated within 30 minutes at a PCI non-capable center. And also, patient should be given the dual antiplatelet, preferably aspirin, P2Y2 inhibitors. Nowadays, ticagrelor is a drug of choice. Prasugrel should be limited if you are sure that PCI can be performed and weight of patient is more than 60 kilos or age of patient is less than 75. The approved fibrinolytic agents, we have streptokinase given in dose of no boluses in this 1.5 million units over 30 to 60 minutes. But the most important side effect of streptokinase is hypotension, and few patients have allergic reaction because of presence of antibodies. You should avoid re-exposure within 6 months. It is not very fibrin specific, and the efficacy in achieving TIMI2 or TIMI3 flow, that is establishing the flow, is about 60 to 68% only. Most commonly used nowadays agent is tenecteplase. It is to be given as bolus. If the weight is 60 kilos, you should give 30 milligrams, 35 milligrams for 60 to 70 kilos, 40 milligrams for 70 to 79, 45 milligrams up to 90 kilos, and 50 milligrams for over 90. It is very fibrin specific and achieves a TIMI2 or 3 flow in almost 85%. And it competes with retiplase, which again has to be given as bolus 10 units and 10 units over 30 minutes. It is also very fibrin specific, and 84% patency rate of the arteries is achieved by using reticulase. Altiplase, again, no bolus required, 15 milligrams, followed by infusion of 0.75 milligrams per kg over the next 2 hours. Total dose not exceeding 100 milligrams. It is fibrin specific and achieves a patency rate of almost 75 to 84%. The pharmaco-invasive strategy. Early thrombolysis either followed by rescue PCI for patients with failed thrombolysis is indicated. Appropriate for patients who are eligible for treatment with fibrinolytic in whom first medical contact to balloon time anticipated is more than 120 minutes, either because of financial delay or because of busy cath lab or in present time waiting for a COVID report. All thrombolyzed patients should be considered for PCI therapy within 3 to 24 hours. Now, STEMI India program is going on. It's a newly developed system towards the practical and equitable ST elevation myocardial infarction for a system connecting rural India, basically. Shorten time to reperfusion through pharmacological means at rural hospital followed by angioplasty at a city hospital. This was the concept by which STEMI India started. Any patients less than 90 minutes time to treatment eligible for angioplasty, please do PCI. But if he has STEMI symptoms, less than 30 minutes of treatment, and presents to a non-PCI capable center, do thrombolysis with pharmacoinvasive approach, and then subject the patient to PCI within 3 to 24 hours. This is what is the substance of the concept. The triage plan for ST elevation in rural and urban India is like this. If the patient presents with STEMI in a big city, primary PCI is the drug of choice, treatment of choice. Hospital-based thrombolytic therapy and then rescue PCI is the second option. If he belongs to a small town, hospital-based thrombolysis followed by rescue PCI or a failed PCI. For failed thrombolysis should be subjected to PCI. If the patient belongs to village, then thrombolysis in the nearest possible hospital, pharmacoinvasive therapy, and then rescue. So this was presented in Indian Heart Journal, STEMI India Program 2017. Then peri-procedural pharmacotherapy, adjuvant antiplatelet therapy to PCI. A potent P2Y2 inhibitor like prasugrel or ticagrelor or clopidogrel, if there is not available or contraindicated, is recommended before PCI and maintained over 12 months. This is very important unless there is a contraindication like excessive risk of bleeding. Class 1 level of evidence A. Aspirin is recommended as soon as possible to all patients without contraindication. Class 1 level of evidence B. We should consider GP2B3A antagonist if there is an no reflow or a high thrombotic burden. Class 2A level of evidence C. Then Canglior may be considered in patients who have not received P2Y2 inhibitors. It's a class 2B level of evidence A. Then peri-procedural adjuvant anticoagulant should be given in addition to antiplatelets 1C. Routine unfractionated heparin, again level of evidence C, class 1. In patients complaining of history of HIT, biliverdin can be recommended as an anticoagulant, class 1 level of evidence C. Routine use of enoxaparin should be considered class 2A level of evidence A. Biliverdin 2A level of evidence A. Fondaparinux is not to be used during PCI. No trials showing evidence of utility of fondaparinux. Then apart from that, patients should be put on oxygen. To patients having overt pulmonary congestion, saturation less than 90% with uncomplicated MI during the first 3 hours. Analgesia can be given using morphine 4 to 8 milligrams, but you should avoid morphine in a setting of inferior MI and suspected RVMI on ECG. Nitroglycerin for the first 24 to 48 hours in AMI with congestive heart failure. Sublingual nitrates 0.4 milligrams can be given in 3 doses over 15 minutes each interval, and IV infusion of 10 microgram per minute could be given if the patient is having high blood pressure or ongoing ischemia and pain. Anticoagulation to all patients with STEMI, unfractionated heparin 60 units per kg to a maximum of 4,000 units, and then infusion of 12 units per kg or a maximum of 1,000 units per hour. So long-term management, we should use beta blockers, which should be initiated initially within 24 hours if there is no contraindication. We should avoid IV without knowledge of LVEF. decreases myocardial oxygen demand and improves myocardial remodeling. It reduces angina, infarct size, and improves the myocardial infarction and improves the mortality. Guidelines advise 3 years of use after MI and indefinite if there are other indications like heart failure. The major studies associated with benefit of beta blocker in STEMI, COMET, TIMI2, and numerous other metalysis are available. Then ACE inhibitors or ARBs, it should be initiated within 24 hours if there are no contraindications, and consider ARB if it is intolerant or allergic to what you say ACE inhibitors. It reduces afterload myocardial remodeling. Benefit largest in the anterior ST elevation MI, heart failure EF less than 40%. Less benefit if it is low risk or no heart failure, revascularized patient. ARNI should be used in patients to reduce death risk of hospitalization if there is heart failure. The major studies supporting it are SAVE, HOPE, Europea, and Paradigm HF. Aldosterone antagonists should be considered in patients having EF less than 35, already on adequate doses of beta blockers, ACE inhibitors, or ARBs. Limited data of benefit without reduced EF is there. It improves myocardial remodeling and may reduce all-cause mortality and rehospitalization. FSS and RAILs are the major trials favoring the use of aldosterone antagonist. Lipid lowering agent, high intensity statins, that is 80 milligrams of atorva or 40 milligrams of rosuvastatin in case of all acute MIs. Consider ezetimibe if the goal of LDL less than 70 is not reached. Ideal should be about 50 milligram per deciliter. It reduces mortality, subsequent cardiovascular event, and also may reduce rate of readmission. Major studies supporting it are A to Z, Prove It and Improve It. So, long term, all the patients should be on beta blockers, ACE, ARB or ARNI, aldosterone antagonist if the EF is less than 35, and statins. Beta blockers in ST elevation MI. Every patient with ST elevation MI should be started on a beta blocker unless contraindicated. As soon as the patient is hemodynamically stable after an MI, and it's to be continued at least for 3 years. In presence of LV dysfunction, beta blocker should be continued indefinitely. The non-ST elevation MI, invasive intervention, that is PCI or CABG, depends on the presence or absence of high risk factors. Ischemia guided therapy is chosen for patients at low risk for recurrent ischemia, for patients at hospital where intervention services are unavailable. Fibrinolytic can be harmful and therefore not indicated. So basically, only use fibrinolytic in ST elevation. Please do not use in non-ST elevation MIs. The approach to NSTMI is within 2 hours, within 24, and delayed 25 to within 24 to 72 hours, and ischemia guided intervention, which depends on spontaneous or provoked ischemia. Immediate within 2 hours, refractory angina, new onset heart failure, new or worsening mitral regurgitation, recurrent angina during maximal medical therapy. Invasive strategies, high risk, that is gray score of more than 140, raised troponin level, new ST elevation, depression. Within 24 to 72 hours, intermediate risk, a gray score of 109 to 140, TIMI score more than 2, ejection fraction less than 40%, post-infarction angina, presence of diabetes, renal insufficiency, prior CABG, recent PCI within 6 months. And depends on spontaneous or provoked ischemia, low risk, that is TIMI score of 0, low risk of and troponin negative in women, patients or physicians' preference, absence of high risk features, unavailability of intervention facilities or expertise. Invasive interventions are those involving coronary angiography with intention to perform PCI or refer to CABG should be done. So basically, difference between NSTEMI and STEMI is in NSTEMI, we should not use fibrinolytic therapy and perform an angio as soon as possible. Early hospital care, again, it represents first we have to treat myocardial supply demand mismatch by giving oxygen, analgesics, nitrates, beta blockers, calcium channel blockers. Then coronary thrombus to be tackled with antiplatelet therapy by administering oral aspirin and P2Y2 inhibitor. Anticoagulant administered as an intravenous anticoagulant to all patients regardless of treatment strategy. Unstable atheroma or progressive atheroma, you should use statins. ACE-ARB should be started to all patients if the EF is less than 40. Patient has hypertension, diabetes, stable chronic kidney disease, and ACE inhibitors may be reasonable for patients with cardiac and other vascular diseases. The antiplatelet aspirin should be started with a loading dose of 150 to 300 milligrams and a maintenance of 75 to 100 milligrams, class 1 level of evidence A. Then P2Y2 inhibitor is recommended in addition to aspirin for 12 months unless there is a contraindication for bleeding risk, in which ticagrelor dose of 180 milligrams loading, 90 milligrams twice BD should be used unless there is contraindication to patients with moderate to high risk of ischemic events regardless of initial treatment strategy. Prasugrel 60 milligrams loading, 10 milligrams per day is recommended for patients proceeding for PCI and no contraindications as I told you. Clopidogrel nowadays, the order of usage has come down but still has a place, recommended in patients who cannot receive ticagrelor or prasugrel and who require oral anticoagulants. P2Y2 administration for a shorter duration, that is 3 to 6 months after DES implantation, may be considered in patients who are having a high risk of bleeding. It's a class 2B indication. It is not recommended to administer prasugrel in patients in whom coronary anatomy is not known. Very important. So prasugrel administration should be only after doing an angiogram. Then parenteral anticoagulant therapy, very important. Parenteral anticoagulant is recommended at the time of diagnosis according to both ischemic and bleeding risks, class 1 level of evidence B. Fondaparinux is recommended at having the most favorable efficacy profile for management strategies. Bilaviridine is recommended as an alternative to unfractionated heparin plus GP2B antagonist. Unfractionated heparin 70 to 100 international units is recommended in patients who are undergoing PCI did not receive any anticoagulants. And crossover between unfractionated and low molecular weight heparin should not be done. In patients with NSTEMI, no prior stroke at a high risk as well as low risk of bleeding, aspirin and clopidogrel should be given. Low dose rivaroxaban can be tried. Then long-term anti-ischemic therapy, early initiation of beta blockers, all patients. Then continue with beta blockers unless the patient goes to Caliph class 3 or higher. Sublingual nitrates to relieve angina. IV preparation is recommended in patients with recurrent angina or uncontrolled hypertension. In suspected or confirmed vasospastic angina, calcium channel blockers should be recommended and not beta blockers. So in summary, ST elevation MI is a patient capable for reperfusion therapy at hospital, capable of PCI, that is the treatment of choice. Not capable of PCI, we should give thrombolytic therapy in form of tenecteplase, streptokinase, altiplase, or retiplase. Then go for PCI if necessary. Dual antiplatelet therapy for all the patients, medical therapy or revascularization depending on the coronary anatomy. And for patients with CABG, continue aspirin, interrupt P2Y2 inhibitor and this one, GP2B antagonist. For primary PCI, continue antiplatelet drugs for at least 12 months unless there is contraindication or high risk of bleeding. For non-ST elevation, directly go for invasive strategy, no role of thrombolytic, and it should be ischemia driven. Dual antiplatelets are to be given. Prasugrel should be given only after knowing the coronary anatomy. Do not switch over anticoagulants unfractionated to low molecular weight heparin. Then for all pre-discharge patients, they should have aspirin 81 milligrams indefinitely, P2Y2 inhibitors for 12 months if there is no contraindication, beta blockers, then EF less than 40, ARBs, ACE and aldosterone antagonists, statins for all the patients. So patients with acute MI, growing concerns in young individuals in India. STEMI India represents a critical phase of acute MI management. Pre-hospital management like ECG, activation of emergency medical service is very important in rural areas. Reperfusion strategies like PCI thrombolysis should be used in the STEMI. PCI capable centers in city areas, primary PCI is the choice if performed within 120 minutes. And thrombolysis can be initiated if the anticipated time is more than 120. Pharmaco-invasive therapy is evolving strategy, and STEMI should be managed on invasive and ischemia-guided therapy. fibrinolytic therapy should not be used for NSTEMI. Thank you.
Thank you, Doctor. Thank you, Dr. Rajiv Gar, for giving an wonderful and excellent presentation on acute MI management in Indian perspective. So, by this, I want to call upon Dr. Mukesh Rao for his next presentation on common mistakes in management of hypertension, sir. Dr. Mukesh Rao, sir.
He is not unmuted, I think. He has to unmute.
Yes, sir. Please unmute, sir.
Yeah, can you hear me now?
Yes, sir. Yes, sir. We can able to hear you. You can present this.
Yeah, just sharing the slides. So
Yes,
at the
thank you,
outset,
sir.
I'd like to thank IPCA 3C Division, ABM Mr. Madan Mohan and Swami for giving me the opportunity to talk on this a common topic of errors in the management of hypertension, along with Dr. Rajiv Garg, who just completed his lucid presentation on management of acute myocardial infarction. So I'm sure it must be very useful to all of you. Now, can you see my slides?
No, you should start sharing.
Yeah, I'm just sharing. Just a minute. Yeah. Sorry for the delay. Just not. Just desktop. Yeah, I'm just doing. Desktop touch.
Till then, we can ask some questions till Mukesh is
Yeah, I have any question? Yeah. Can you see now?
No, you should start sharing.
Okay. Yeah. Any questions?
Sir, start your camera.
Yeah, I'll do that. Just a minute.
Yeah, now we are able to see.
Yeah. Camera. I'll share. Yeah.
Yeah, now we are able to see.
Coming to,
no problem.
Yeah. You can see me also? Okay.
No, now only your slides will be there.
Okay, yeah. So common mistakes in the management of hypertension. So the important errors what usually committed are: one is inappropriate measurement of BP, two incorrect diagnosis, three medication contraindicated in specific disease, given monotherapy who requires a combination of therapy, lack of adherence especially in elderly. So these are the common errors which happen. So inappropriate measurement of blood pressure. So what happens if we inappropriately measure? Overestimation of blood pressure. Overestimation of blood pressure by just 5 millimeters can lead to inappropriate treatment of approximately 30 million patients. So unnecessary treatment and cost, potential side effects of medicines, mislabeling as hypertensive with attendant psychological issues. So underestimation of blood pressure, on the contrary, if we by 5 millimeters, mislabel approximately 20 million patients with pre-hypertension when they would have true hypertension and would have got benefited by treatment or lifestyle modification. So we all know about these cuff sizes. The ideal cuff should have a bladder length that is 80% and the width that is at least 40% of the arm circumferences. Most present-day cuffs have an index marker and range marker which can assist in preventing miscuffing without the need for measuring the arm circumference. If the index marker is within the range, the cuff is of appropriate size for the patient. So the American Heart Association also recommended cuff sizes based on the arm circumference. Before buying a machine, I think we should look at the markers on the cuff, and that would really help. And most of these manufacturers, they'll give 2 cuffs, so Omron and all. Ideally, we should buy 2 cuffs and keep it in the clinic or wherever we are working. The selection criteria for BP cuff size for measurement of blood pressure in adults. So 20 to 26 centimeters of arm circumference, it is called small adult. For adult, 27 to 34, large adult, 35 to 44. Adult height is 45 to 52. So 6 common errors that can lead to inaccurately elevated blood pressure readings, according to American Heart Association, are poor sitting posture. So stooping forward should be avoided. Person should be ideally sitting upright with back support. So it is preferable if we can buy a stool or chair which has a back support and check the BP on that. Unsupported arm, ideally the arm should be supported or resting on a table. Wrapping the cuff over a clothing. A cuff that's too small for your arm. Talking while taking the blood pressure should be avoided, and having a full bladder. Apart from that, no coffee, tea for the preceding 30 minutes. And the both feet should be firmly on the ground. They should not sit with crossed legs. That again will give a false reading. So these are the basic things. So incorrect diagnosis brings more complications. So misdiagnosis. A misdiagnosis could result in delayed treatment, which may cause other complications or more severe illness. An inappropriate follow-up plan was one of the common reasons for misdiagnosis. Reasons for inappropriate follow-up include lack of follow-up, incorrect intervals for follow-up, no documentation of follow-up. Hypertension diagnosis and management error taxonomy. If you look at first in the diagnosis part, the hypertension diagnosis, it can be misdiagnosis if the SBP less than 140 and 90. And hypertensive diagnosis, no history of hypertension diagnosis or no history of antihypertensive medicines. Incomplete diagnosis is when hypertension diagnosis and no record of blood pressure. Next is no hypertension diagnosis, that is called misdiagnosis. Systolic blood pressure more than 140, diastolic more than 90, and no hypertension diagnosis. So next is intervention part, treatment part. Omission of essentials, medications, hypertension diagnosis with BP more than 140 by 90, and no antihypertensive medicines prescribed. No history of use of antihypertensive medicine. Next is patient teaching, hypertension diagnosis of more than 120 by 80, and no lifestyle modification related patient teaching. So it is important that between 120, 80 and 140 by 90, we should emphasize on lifestyle modification based on the SPRINT trial. Pharmacological therapy can be started above for 140 by 90, but it is very much important that we should advise lifestyle modification and try to keep the blood pressure below 120, 80, because between 120 to 140 and 80 to 90, it is there for longer time. Already there is a target organ damage that starts. So this is an important point. In the follow-up, antihypertensive medication is prescribed, but follow-up is not documented. Next is in medications, antihypertensive medication contraindicated for specific diseases. So these are the errors of taxonomy. So errors encountered in hypertension management. In terms of errors related to hypertension management, the rate of errors of omission for medications as well as for patient teaching was higher than that of inappropriate treatment prescribing contraindicated medicines. Medication errors are the most frequently reported type of error by healthcare providers, and omission of medication is the most frequent type of medication error. So BP patterns based on office and out of office measurement. So normotensive, when they have no hypertension either in office or home BP. Sustained hypertension, they have high blood pressure recordings both in clinic as well as at home. Masked hypertension, their office blood pressure is normal, but home BP is more. White coat hypertension is the reverse, when they have high blood pressure at clinic, but normotensive at home. So medication contraindicated in specific comorbidities. So indications and contraindications to major classes of antihypertensive drugs. So diuretics, conditions favoring their use are heart failure, elderly, isolated historic hypertension, African origin. But contraindications, gout, and possible pregnancy. So before starting any patient on antihypertensive drugs, so routinely we do electrolytes, CBP, ECG, and all. We should do uric acid also. So loop diuretics, end-stage heart failure and renal and congestive cardiac failure. Diuretics, anti-aldosterone, like that already discussed, CHF post-MI. Contraindications are renal failure and hyperkalemia, mainly mineralocorticoid antagonists like eplerenone and aldosterone. Beta blockers, conditions favoring are angina, CHF, pregnancy, tachyarrhythmias. And contraindications, relative contraindication is asthma, COPD, but absolute contraindication is AV block. Peripheral vascular disease, glucose intolerance, and that we can use with a little bit of caution. Calcium antagonists, mainly dihydropyridine group. Main indications are elderly, isolated systolic hypertension, angina, peripheral vascular disease, carotid atherosclerosis, pregnancy. Possible contraindications are tachyarrhythmias and congestive cardiac failure. That is amlodipine. So calcium antagonist is verapamil and diltiazem. They can be used in angina, supraventricular tachycardia, carotid atherosclerosis. But absolute contraindication is again congestive cardiac failure as well as high degree AV blocks. ACE inhibitors, conditions that help in favoring their use are heart failure, LV dysfunction, post-MI, non-diabetic nephropathy, type 1 diabetes, proteinuria. Contraindications, pregnancy, hyperkalemia, suspected bilateral renal artery stenosis. ARBs, indications are type 2 diabetes, proteinuria, diabetic microalbuminuria, LVH, ACE inhibitor induced cough. Contraindications are again pregnancy, hyperkalemia, and suspected bilateral renal artery stenosis. Alpha blockers can be used in BPH, hyperlipidemia, and contraindications are orthostatic hypotension and congestive heart failure. Relative contraindication. So this is important to know the indications, contraindications. So concepts of antihypertensive medication, contraindicated in specific disease and their errors. So ACE inhibitors, again discussed already, contraindicated in pregnancy, angioedema. So, and then ARBs, again pregnancy, beta blockers, asthma, reactive airway disease, high degree AV blocks, thiazide gout. So contraindicated antihypertensive medication related errors were identified in about 11.6% of encounters with diagnosis of hypertension and asthma. Given monotherapy, who requires combination therapy? This is another error. BP control rates are suboptimal with monotherapy. Nowadays, most of the time, combination therapy is recommended to ensure compliance as well as efficacy. More than 75% of hypertensive patients do not have adequate BP control with monotherapy. They require combination therapy. Lack of adherence, especially in elderly. Non-compliance and non-adherence. If you look at this slide, only 1 in 7 people with high blood pressure have it adequately controlled. 1 in 4 patients on antihypertensives are not taking prescribed medicines. Adherence in the elderly population is becoming a growing issue of concern. Reasons for non-adherence in elderly: decline in cognitive function, decline in physical well-being, multiple comorbidities, and complex treatment regimens. We should keep it simple. The silent killer nature of the hypertension is again a big problem. The silent killer nature of hypertension has an impact on patients' adherence to treatment for the condition as well as the initiation of therapy. Like many other non-communicable diseases, hypertension does not show signs of manifestation until the serious systemic and organ damage that can appear years after diagnosis becomes symptomatic. The high impacts of hypertension. More than 1 billion people globally are living with high blood pressure. By the next 5 years, it is estimated that over 1.5 billion people will have hypertension, which is a huge number. So that concludes my talk. And any questions, comments? The webinar is open for discussion. Yeah, any Any questions, comments? Madan, am I audible here?
Yeah, you're audible.
Yeah.
Nice presentation for an uncommon topic, complicated, common errors. It's very nice. But if you see the importance, almost we commit errors in 10% of our diagnosis, either overdiagnose or underdiagnose. Very important it is.
And
So
then with the problem is with, I think, home BP, many patients, we have to
Correct.
train them how to take the blood pressure properly.
Yes, yes.
The biggest problem is they come with their own numbers and then we are confused. So, isn't it? Your experience, because everybody is having a BP apparatus at home. So I think,
And the situation, you should always give a grace of 20/5 at least, I feel.
Okay.
Because symptomatic, sympathetic stimulation by going to a clinic itself increases your systolic BP by 15 to 20.
Okay.
So that is one. Second, as you told already, calm, relaxation, avoid smoking, which is not possible. Then ours itself, clinic, we are busy. So we tend to shoo off the patient early. Then second, our nurse does the measurement. Then our assistant does the measurement. So they must be totally qualified, which is very difficult proposition nowadays. Then cup size, as you rightly pointed out, we should have large, medium, and small cups in our clinic, which is not possible. Then calibration of BP apparatus.
Yeah, very important point. Yes.
Very important. And now we are switching over to digital, so that is very important. Still, I feel mercury was good, but digital is very sensitive. So you overestimate sometimes, and press alarm buttons, and he will ring you like in the night, sir, I am having a BP of almost 200, so much. Probably it might not be there, but because we have to go with the times.
Yes,
And
the very important point you were mentioning was calibration of BP apparatuses.
Yeah, very important.
I think we all should calibrate our BP apparatus every yearly and then put a label behind it.
Yes, date
this
of
is
calibration.
Very important. Otherwise, it will give false readings. That's a very important point. Yeah. And we have to move on to digital because mercury is banned in
and
you
cup
have to learn
size.
to live with cuff size. That is a big problem.
Obese patients we tend to underestimate, and thin patients we overestimate.
So thank you, Doctor. Thank you, Dr. Mukesh Rao, for your presentation. And I want to thank both Dr. Rajiv Garg and Dr. Mukesh Rao in their busy schedule. They have given us time for presenting this management of hypertensions in both like acute MI management and common mistakes. So I once again I want to thanks for giving the time for IPCA for giving presentation on this webinars. So,
thank you.
And that's all from our side, sir. Thank you.
Thank you. Good night, Mukesh. Good night.
Good night, boys.
Chalo.
Technical team, we can close, no?
Yes, sir.
Yeah, thank you.